everybody. I would like to introduce a title under the name of Diagnostic and Therapeutic Value of Diagnostic Laparoscopy in Patients with Chronic Abdominal Pain. Introduction. Chronic abdominal pain is a troublesome dilemma confronting both the medical and surgical care professionals. No precise etiology of the problem could be elicited. Diagnostic laparoscopy, apart from visualizing a large part of abdominal cavity and biopsy, can be done. The introduction of laparoscopic surgery have been increasingly recognized as a procedure that offers precise visual assessment of intra-abdominal condition for diagnosis and prompt intervention. Avoid unnecessary laparotomy, provide accurate diagnosis, plan surgical treatment, and identify abnormal findings, improve the outcome in a majority of patients with chronic abdominal pain. Material and methods. Patients with the inclusion criteria underwent diagnostic laparoscopy for chronic abdominal pain over last 2 years from January 2012 to December 2013. The demographic data will include it and the length of time with pain. Diagnostic studies also is done, intraoperative findings and interventions and follow-up. Actually, this is a movie for intra-abdominal small intestine during laparoscopic procedure with intestinal obstruction at the level of the small intestine. Was surprising during diagnostic laparoscopy, we find one big small intestinal stone. Here, we try to find the site of the obstruction. Actually, this is a distended proximal lobe. And this is the distal collapsed one appearing here. This is a collapsed lobe. Here is the stone. We find it obstructing the small intestine and find it during laparoscopy, which is done previously as a diagnostic part. This is the stone. Results. In this study, 80 patients, 55 female and 25 male, with an average age of 25 years, underwent a diagnostic laparoscopy for the evaluation and the treatment of chronic abdominal pain. The demographic data of the patients used in the study, the age with a mean age 23 years, ranging from 18 to 52. About the sex, 25 male and 55 females, and the duration of pain ranging from 4 months to 29 months, and the site of pain ranging from upper abdomen, lower abdomen or diffuse, upper abdomen in 9 patients, lower abdomen in 53 patients, and diffuse in 18 patients. Identified different pathology: abdominal TB 5%, internal herniation in 2 patients, significant intra-abdominal adhesions in 18 patients, secondary intussusception in 2 patients, small intestinal stone, which you find previously, 1, intestinal lymphoma, 1 patient, abdominal lymphoma due to mesenteric lymph node, 2 patients, inflamed cecal diverticulum 2, inflamed jejunal diverticulum 1, inflamed Meckel's diverticulum 1, and appendicitis 19, Crohn's disease 2 patients, and endometriosis 3 patients. In no pathology detected, 22 patients and 27.5%. Improvement of pain 71 in 71 patients, and diagnostic accuracy 58. Conclusion: diagnostic laparoscopy seems to be a simple, rapid, and effective diagnostic tool in evaluating patients with chronic abdominal pain in whom conventional methods of investigations have failed to elicit certain cause, with the advantage that it is an effective therapeutic tool, accurate, and easy tissue sampling. Thank you.
Thank you, Dr. Monem. Any questions from the audience? Thank you. There was a question, sorry. There are questions.
Thank you, Dr. Ahmed Abdel Monem. Thank you very much.
Thank you.
Diagnostic laparoscopy is very useful for diagnosing the vague abdominal cases. I did not see that the investigation before the laparoscopy here. I don't know. CT scan, like if we have good machine, CT abdomen, and good radiologist, most of the cases it should be diagnosed by CT scan. Rather going to laparoscopy, which is an invasive procedure, under GE, or it's an invasive procedure still. So I don't know. Now the main surgeon or fair, maybe CT scan should be. The investigation of choice before taking the patient to laparoscopic, diagnostic laparoscopy. Especially you mentioned that the negative laparoscopy was 27 in your series, isn't it?
Okay. In the study, I see that a lot of missed pathology during a lot of investigations done before laparoscopy. We find a lot of patients missed, even with very simple procedures and very simple pathology like acute appendicitis. Some radiologists cannot diagnose in conventional radiology, CT, something like that. A lot cannot read the pathology. So in this study, I think that if you see the pathology by your eye during laparoscopy, this is the target, and you can get it and cure in the same time. Yeah. Diagnostic means that we begin as a diagnosis to take the, yeah.
If you can get the diagnosis by CT scan, so you take the patient to CT scan or
not all
laparoscopy.
pathology.
Laparoscopy is invasive.
Yeah. I am with you, but not all CT scan can detect all types of pathology. You cannot see, but if you see by your eye and directly with the laparoscopy, I think this will solve the problem. A lot of pathology, you can see it.
But laparoscopy is not without complication.
Yeah, sure.
Serious complication.
Yeah, it is without complication, but now the diagnosis with the laparoscopy in well and expert hand is very easy and take no time.
Yes, sir. Usually we do ultrasound and CT scan in all the cases. But if you miss it, sometimes we can catch this such episodes like that. That's what is meaning. Correct.
Any more questions? Yes, please. Doctor, identify yourself, please.
Good afternoon, sir. I'm Gayatri Tailani from India. Sir, I had a question to both of you. Sir, out of the causes that you listed in the table, easily ultrasound and CT can diagnose internal herniation and interceptions and even stones, right? CT. Like ultrasonography and CT can diagnose most of the causes. So once we've excluded those, and I had 2-3 cases in our hospital which were of adhesions which the CT could not diagnose. That's why we conserved the patient for over months, and when we could not actually find a cause with ultrasonography and CT, that's when we did a diagnostic lab. And out of those 4 to 5 cases that we saw, 3 of them had adhesions. So in the other cases, would you not exclude them when you get internal herniation and interception, because they are easily diagnosed, like interception has target sign on CT and stuff, so they are easily diagnosable, right?
Here in this study, we began to proceed with diagnostic laparoscopy in patients with vague abdominal pain not diagnosed or not identified for a long time by different techniques of investigations. If you go to these patients and a lot of investigations done with the patient still no improvement, still have pain for a long time, and you cannot assist by different maneuvers or different investigations, included ultrasound or CT or something like that, and the patient still have pain, vague upper abdominal, lower abdominal, I think you can proceed with diagnostic laparoscopy to see. A lot of patients discovered during this diagnostic laparoscopy, and we proceed for curative during in situ also.
Thank you, Doctor. That's clear. Question, answer to your question. Any more questions? Thank you. One last question. One more.
Hi, I'm Khadija from Oman. It's more of a comment than a question. What would actually be interesting now is to go back and look at their previous scans and just see if it's actually been missed in the scan, or was it shown in the scan, or you get what I'm saying?
Again, sorry?
It's a comment. What would actually be interesting now is to go back to the previous scans that these patients have had and just to see, like, for example, the stone. Was it there? Was it missed?
You want to see it again?
No. What I'm trying to say is that it would be interesting, for example, if that patient has had a CT scan done and the stone was missed.
Yeah.
It says something about the accuracy of.
It is just a missed stone,
Yeah, like the accuracy of the scan or the accuracy of the person reading the scan. So
this represents one patient from 81, okay, and it is missed also with the CT scan. This doctor called about it. It is missed. No, we didn't find it before. No.
Thank you very much, Dr.
Thank you.
Monem.